Hello, good evening, and welcome to this evening's Facebook Live. My name is Alec O'Dare. I'm the Managing Director for Wound Care People. Tonight's session is empowering patients' independence, the impact of adjustable compression wrap systems for lymphedema and venous leg ulcers. The presenters are Dr. Melanie Thomas, who's a Clinical Director for Lymphoedema Wales, and Karen Morgan, who's the Lymphoedema Wales Clinical Network, who've done some fantastic research just recently, which they'll be sharing with us. Tonight's sponsors are L&R, so I'd like to thank those for supporting the event. We know there's a lot going on today. We're not going to talk about that at all, but we have decided that because it was July the 4th that this event has taken place, and because obviously wrap systems are all about empowering patient independence, we would launch a new initiative, which today is the first day that we launch it, which is all around patient independence. We sent out some packs to some of you in the post. I think 180 of you received packs with an advanced copy of the paper that Karen and Mel are going to be discussing with us this evening. So I hope they all arrived in time and you're all settled down and ready to watch. I know Karen and Mel are eager to go. So Karen, Mel, how are you both?
Sure. It's been very busy.
Well, we've been sworn that we're not allowed to mention anything about anything other than Independence Day. So that's it. Hopefully, this will be a nice. Not only look, firstly, on a serious note, this is a very serious subject, and I think the content is fantastic. But hopefully, it's just nice for people to get away from the news for a bit and just focus on some other things that'll keep them entertained. So that's your job, Mel and Karen. I'm going to hand over to you. I'm going to hand over to you just shortly, and I'll be joining you then for a Q&A afterwards. We've got some interactive polls taking place throughout the presentation. So keep an eye on your phones, your iPads, your computers, or something, because you can actually press the buttons that on the polls. I think that's it. Other than just a little bit of housekeeping, you can see that we're doing this. I'm in my house. Karen and Mel are still working, which is shocking. So they're in the office. So if we do have any technical problems, then just bear with us. As always, certificates will be available at the end. Please ask as many questions throughout as you possibly can, or as you want to, because they'll be used for the live Q&A. And do let us know if you did get one of our viewing packs, and indeed what you thought of it, because we had a bit of a chocolate meltdown here at O'Dare HQ, where we were planning on sending lots of chocolates out in these bags, and then we had that really hot day last week, and all the chocolate melted. So I had to frantically go and buy lots of other things to send out, but hopefully everyone is enjoying those. Karen, Mel, over to you. I'll see you after the presentation.
Thank you very much. And of course, that was all lies with Alec. He ate all of the chocolate and then he had to go and buy more. So welcome everybody to tonight. My name is Melanie Thomas and I'm the Clinical Director of Lymphoedema Wales. And here we are celebrating Independence Day, July the 4th. And it's great because I'm going to Florida, closer to the end of the summer. So Karen, welcome. Hello.
Hello, everybody. Welcome. Yeah, Independence Day. And I know we're not talking about anything, but I will talk about some independence that is happening for me. This is my first week of semi-retirement, so it is real independence for me this week. So that's exciting news as well, but not ready to completely go, so still hanging on in there. But yeah, we'll talk about empowering, independence, and all about the compression wrap. So let's go.
So there will be some live questions later on, but what are we going to talk about tonight? Now, for those of you who know Karen and I or have heard us talk before, we can chat for Wales. So we're going to try and keep it as succinct, as a posh word, as succinct as much as we can. But we are going to talk about empowerment. And that's not only empowering our patients, but it's empowering us as healthcare professionals. Because I don't know about you guys, but sometimes, do you know, I feel as if I'm just on the motorway, I'm just going, I can't even remember what I've done. I've got 10 patients waiting to come in. And sometimes I'm just like on that treadmill doing the same thing. So I'd love a bit of empowerment sometimes. Independence, yeah, definitely. I don't know, again, you feel as if you're doing the same things over and over. And really, what are the outcomes? What are we changing? How can we make our patients more independent? Do they actually want to be independent? Do they love us coming to see them, or them actually coming to see us because we are the only people that they might see? We're going to talk about value. Now, for those of you who live in Wales, value-based healthcare, it's a big thing in Wales, and it's understanding more about what is really important to patients and their families, and what can we do to make sure that we get the outcomes for them of what they really value. And how do you do that? Well, shared decision making. It's not our things that we want them to do, it's what they want us to do, on how we can work together. Again, sometimes I assess patients and I think, straight away I'm in there washing those legs, bandaging those legs. And then I think, actually, I've even said to the patient, this is what it's going to entail. It may actually hinder your life. How can we stop you being as or promoting independence? So sometimes we've got to work together. And then the last thing, it's cost. How much is everything that we are doing, but cost in money, but cost to the patient and cost to us? And then are wraps a potential solution to all of these things? So these are patients that we readily see, and I'm sure you all see them too. There's 6 patients here, and we're going to come back to these 6 patients at the end of the presentation to think about, could we try something different with them? But these are all legs. We obviously see arms as well, and head and neck, and we see breast edemas and genital edemas. And these are some of our lymphedema facts. Remember, if a patient has swelling and it lasts longer than 3 months, then potentially that is chronic swelling. And what that means is your lymphatic system has failed, so it's actually lymphedema. And lots of people get their knickers in the twist about this because they think, oh no, that isn't lymphedema, it's chronic edema, or it's chronic swelling. Well, let me tell you, if you get swelling and it lasts longer than 3 months, it's lymphedema. It's as simple as that. Now, lymphedema can occur anywhere in the body, as I've said, and it can occur at any age. This week, we had a 4-day-old baby referred to us, and this is the 3rd little baby that we've had in the last couple of years. The oldest patient is over 100, and obviously, the older you get, the more likely it is that you're going to get some sort of swelling. And the reason for that is, Karen, what have we done all day today?
Sat at the desk. We haven't moved much. My poor lymphatics are screaming at me, to be honest. Get up and move. Do your 10,000 steps. I certainly haven't done them. I'll do them when I finish, but I certainly haven't done them yet. So, that's where we live. More people are home working, moving less. Find the closest car park to the shop. Don't walk too far. That's the society we're currently living in.
And that's so true, isn't it? So if you've got lymphedema, well, you've got physical problems. You know this. Skin problems, cellulitis, wounds. You can't get your shoes on, you're more at risk of falls because you've got foot edema. You may have fungal infections. Then there's this huge psychological and emotional and functional burden. Now, in Wales, we've just employed 2 consultant psychologists, and that was based on some of the work we did on patient-reported outcome measures, because anxiety, body image, these were all high impacts because of people having lymphedema. And then functional, they can't do what they want to do. And we know this from the patients that we see. So from an NHS perspective, we know that lymphedema, cellulitis, wounds. How much do wounds cost currently? 8 billion. That's a lot of money. And if we can get rid of that edema, that lymphedema, then those wounds are more likely to heal. But if you don't get rid of the edema, then those wounds are really hard to improve on. Falls, as I've said, I'm a physio by background, muscle strength, they're not using their muscles as much, then obviously they're more at risk of falls. The other thing is where lymphedema occurs, sometimes we shunt that fluid up and it goes in the knee, then suddenly they've got knee pain, they've got swelling on that knee, they're not walking as much as they should be, their gait is altered, they're more at risk of falls again. So we know there's lots of wasted resources, there's harm, there's waste, there's variation. What happens here in Wales doesn't happen in England, doesn't happen in Scotland, Ireland. It's all different everywhere. And it should be different because patients are different and they are all independent. Hopefully, that's what we want to promote to them. But they are different. And then all of this pressure all comes and it's costing and the impact. Now, Kat, how does lymphedema affect us patients then?
Yeah, I think it's important to think of this. We often think about the patient who's in front of us, but when you think of the risk factors associated with developing lymphedema, all of us are potential patients. So Mel mentioned about what we've been sitting and doing all day. And so we need to relate this to how we would feel and how patients feel as well. So their quality of life is impacted. Mel has already mentioned that we've managed to secure funding and I've got 2 consultant psychologists. The psychological issues are massive. The physical issues, not being able to do what they used to do, unable to work and dependency on others. And it's, even though, you know, in Wales, people think we've got it right, it's still a poorly understood condition, even in Wales and throughout the UK and internationally. Obesity and then the social impact. You know, for me, I think we burden patients. We, like Mel said at the beginning, we say, okay, you've got this condition with your legs, we need to bandage your legs, we need to do this. Do we truly have a discussion around what would be a benefit to the patient and what do they want and what's their priority? So we'll talk about that a little bit more now. So how can we help our patients to help themselves? The absolute start of it all is increasing knowledge, healthcare professionals' knowledge, but also patients. We need to make sure our patients are well informed. You know, we need to problem solve with them and we need to empower them. If you think of a caseload of patients that you might have or patients that you see, we disempower them. We quite often disempower them by taking control of looking after their legs. I think often patients are referred too late on, and then they might, you know, there's a lot of work in Wales, we're looking at proactive work where we go to find these well legs and keep the legs well. I think legs should be much higher up on the agenda, and we should actually discuss with the patient in a true shared decision how would they like to manage their legs? Because actually we create them to become dependent. We need to change the language we use, much more proactive, much more, and actually accept what they want to do to manage themselves, reducing the risk of complications. It might not be what you or I would want to do, but actually they're the patient's leg or the person's legs in front of you.
Okay, so these are all things that we tell our patients to do. So if we look at the first one, compression garments, wear it for 8 hours, wear it for 6 hours, wear it for 2 hours, wear it for 24 hours. Where's the evidence? There is no evidence really. You know, we know that if you wear compression, then your swelling will go down. But there's no rhyme, no reason, no evidence to say 6 hours is better than 5. 7 hours is better than 3 hours. You know, it's down to those individual patients. But if you imagine wearing garments, wearing bandages, you know, wraps, it is a bit of a burden to some patients. Their body image is affected. People are asking them, what's happened to your leg? Why have you got that on? They can't sometimes get their shoes on. And it is that constant reminder of what's going on. Now, may affect their activities of daily living. But really, sometimes patients like that attention too. And we must also, you know, we need to remember that about sometimes compliance isn't as great. And why isn't it so great? And that's where our psychologists are trying to teach us as healthcare professionals, you know, to improve the communication that we use to try and improve concordance and independence. Then if you think about skincare, exercise, weight management, we tell all these patients to do these things. And when do we tell them to do it? Well, normally, if you're lucky, they're referred to a lymphedema service and they're actually treated for an hour and a half maximum for an assessment. Then we might see them twice a year, and that might be 30 to 45 minutes long. So in total, 3 hours of direct care. And we are telling them to do this, that, and everything else. What happens for the other 8,445 hours? They're left to self-manage. And then it makes you think, why don't patients self-manage? I've told them everything. I told them, I assessed them. I told them that they've got to moisturize the skin. They've got to exercise with these exercise leaflets. They've got to lose weight. They've got to wear this garment. And suddenly I've told them everything I want to tell them. in that 45 minutes, and then I expect them to do everything without me in their little pocket telling them to do this and that. And, that's where shared decision making should be coming in. But we do cram everything to our patients because we want to help them. We are good healthcare professionals. We want to impact our knowledge on them. But really, the psychologists are keeping telling us, take a step back, let them do the talking. You do the listening, ask them exactly why they can't self-manage, and then think about this burden or benefit. So value-based healthcare, this is a typical patient, okay? Bad legs, how long? 6 years. Okay, who's treated them in the 6 years? Community nurses have gone in, been referred to dermatology, back and forth the GP, seen the vascular nurse. They might have been referred to lymphedema. They've seen physios, OTs, you name it, they've got them all coming in. But actually, are they any better? No, the legs are exactly the same. What outcomes have improved? We don't know because we didn't collect any when we started the treatment off 6 years ago. And lastly, you think, well, how much has it costed? How many times has a district nurse gone in? How many different bandages, different dressings, different garments have we used? And what if we cost that? And I can tell you now, it would probably cost thousands and thousands and thousands. So value-based healthcare is looking at the value of what we do, the outcomes, so are they getting better, are they getting worse, and then over the cost of what is actually costed to get them to improve or not improve. And this is where value-based healthcare comes along. So, Karen, tell us more.
Okay, so individualized approach. So we collect clinical reported outcome measures. Well, most of us do. Sometimes we collect them without even know that they're clinical reported outcome measures. So what's the volume in the leg? If we talk about legs, what's the measurements? So we measure. What's their range of movement? Do any of those improve or decrease? So does the volume decrease with the treatment you're using? Does the range of movement improve? What's their muscle strength? Are they having less cellulitis episodes? Are their wounds healing? Is their skin improving? So is the papillomatosis, the hyperkeratosis, the dry areas improving? Is the pain and quality of life improving? The way you can put the money cost around that, or the cost around it, is, okay, are we using less dressings? Are we using less bandages? How many times are they going into hospital? How many times have they been to the GP? So if you're looking how valuable your treatment is and effective, those are the things that you would collect. Now, for a patient, those outcomes might be very different. The patient reported outcomes, what's the impact on the patient? It's all well and good, the wound is healing, the dressings are less, but is the wound more painful? Can they get their shoes on? Can they go swimming? What is the patient's outcome? Because as we all know, if they concentrate on the outcome they want to improve, they're more engaged with you. So as Mel said, if you listen to people, you can understand what their priority is. And I do feel sometimes that we don't consider how the patient is going to cope with the compression wrap, the bandages, the smell of the wound dressing, the smell of the wounds. They can't no longer go on holidays. So actually the way we collect this is we collect a lymprom. So it's a lymphedema patient-reported outcome measure going through validation at the moment. This has opened our eyes massively in clinical practice because what we thought was a priority very much was not the patient's priority. And if we are going to label people being non-concordant or non-compliant, then we need to understand what are they non-concordant to. So actually this allows us to understand what their priority is and how we can engage with the person and improve that for them. It might not be heal the wound, it might be get a pair of shoes on. If they can get a pair of shoes on and they can mobilize better and move better, their wound will improve because the muscle pump will be better. So actually your clinical outcome will it be achieved, but at their progress, at their pace, and when they want to improve it and how they want to improve it. So it's really key. Mel.
Okay, so how can RAPs change our practice? Can they make patients more independent? Can we empower them and us by RAPs? Now, RAPs have been around a long time. One of the first papers back in the millennium, and it was looking at adjustable compression devices, and that was actually by Eilish Lund. an Irish lady who started me off in the world of lymphedema. But currently, there are lots of wraps available from different industries. They've all got slightly different specifications, but they're all of a similar price. But you can have a foot piece, a calf piece, a knee piece, a thigh piece. And also, they come in upper limbs as well. And they come usually in two colours, black or beige. So how do they work? Well, they're adjustable. They're Velcroed. Something that's really good with a wrap is if you put a garment on a patient and within sort of a month that limb has gone down in size, you need to produce a new garment. You need to purchase another garment for them in a smaller size. With a wrap, you just actually make the wrap tighter. So that, although the wraps are slightly more expensive than garments, you may not have to purchase another one if that limb is decreasing in size. It's a low pressure system, high standing pressure. It does reduce the pressure over 24 hours. So exactly like our bandages do. So we bandage somebody up and they all say, oh, love, that bandage you gave me, it was no good. It was falling off the next day. And I'm like, yeah, fantastic. That means your leg's gone down. And that means now that we're going to do another bandage today and it's going to be smaller. Now with a wrap, it's the same thing. But of course, you must make it smaller. So when that limb goes down, you tighten up the wrap. So then it's the pressure when you're moving, the muscle pump is pumping against it, pushing that fluid up, but it's got to be made tighter. It does reduce edema, it does reshape, and it does decrease wound size. And how it works, again, it's very similar to bandages. It's got that 50% overlap. So the research, medium to low quality, but it is improving. When we did our literature search for the study that we did, I got to say it wasn't as much evidence as we thought, but it has improved in the last 5 to 10 years. So you can see there, we know wraps are used for leg ulcers. They're used instead of bandaging in the intensive phase of lymphedema. Sometimes they can be used to go to bed, so nighttime garments. It can be seen as an alternative to compression stockings, especially for the elderly. And we'll talk about that in a minute. What we do know is wraps sometimes produce consistent pressure. Karen, why is that important?
Why is that important? So for me, we know that lots of patients are in suboptimal compression. We know that it's a nationwide issue. If we can apply optimal compression, which is consistent, then we're more likely to heal the wound. We're more likely to reduce the edema. But allowing a patient to be in charge of that is key in independence. I would argue, which we'll go on to talk about in a minute, are we all competent and confident of the pressures we apply in bandages? Have a think about it. I've got views on it, but I won't share it too much for a minute. Okay, so indications and contraindications for wraps. Are there any? I think we think of wraps as a last resort. You might not agree with that, but I often see in practice that it's usually when somebody's tried everything else. Okay, thinking about that, have we disempowered that patient at that point because we've taken control? So there isn't, in relation to, there are no, the indications of use are anybody with edema, anybody with a wound. And when we start talking about ABPI, there's lots of guidance now, the wound care strategy, the All Wales TVN standards, about actually if we delay compression, we cause more harm. But we have to consider those who have arterial insufficiency. So we know that 0.6 to 0.8 on an ABPI can be a significant arterial disease. However, if they have edema, I would challenge anybody that ABPI is incorrect or not accurate. So I think in relation to ABPI, you've got to be very cautious and look at the evidence. We fear applying optimum compression and that fear factor. And actually, I would argue that we're actually putting people at more risk by not doing it. So what about heart failure? Yeah. If the heart failure is controlled, there is no reason why they cannot have a wrap, they can't have a garment or any form of compression. Deep vein thrombosis, we know that there's NICE guidelines, and once that patient is anticoagulized, then they should have compression on. Untreated cancer, again, no evidence. You're allowing people to manage swollen legs, which will increase their mobility and actually keep them as well as they can be with a cancer treatment or not, and lots of other comorbidities. Cellulitis, the reason that we would reduce the compression possibly is because that area is painful. There is no evidence to say to stop the compression, and you're actually in a very difficult and challenging situation if you do stop it, because you're dealing with the chronic edema and the acute edema, and somebody that you might have got quite well controlled prior to having cellulitis will become a complicated leg or arm again. Renal failure, the same. You collaborate with a specialist, and if it's about moving the fluid from the foot up the leg a little bit, just to be able to allow them to mobilize and reduce the risk of falls, that is key. And obviously diabetes, again, it's a holistic assessment. The benefits of wraps for me are they're reusable, they're adjustable, so they can be reduced as the swelling goes down, as Mel has already mentioned. They are really easy to apply, and there is a great, we can actually promote independence from the word go. We've talked about the fact that we wait too late to use them. I think we need to clinically revisit why we're not considering wraps as a first treatment rather than a last. Because you're empowering the patient straight away and you're giving them control. And Mel has already talked about we're only with them for 3 hours out of the 3, I can't even remember how many hours it was, but a lot. It's 0.03% of the time. They're in control, they're managing. So it can be worn under clothes, it can. You know, they're not as bulky as they were. The L&R wrap is on our compression garment formulary within Wales. It is our first choice, but obviously that's a shared decision with the patient. I think I would like you all to think about shared decision in the fact, what decision do we allow the patient to have? I recently presented and think sometimes the only decision we offer is, do they want it in black or beige? You know, how does that empower somebody? So really think about what would work for their lifestyle. It can be removed in the patient, for the patient to shower. You know, bandages are on completely and always on and never come off. And it can be used as well in treatments that are already ongoing. So if we talk about confidence, we're talking about healthcare professional confidence as well. So actually, how do we know what compression they're applying? So it can go over a garment or over bandages, and it can be a mix and match product. There we are. Thanks.
Okay, so these are all the positives, but are there any negatives? Well, my biggest one is sometimes we give a wrap and we think that patient will apply it correctly, and they do apply it correctly, but they don't tighten it enough. So will they apply the right compression? But again, it goes back to promoting independence. Who's in charge? They are in charge. And we all get off days. We all get days where we think, oh, I can't be bothered to diet. I can't be bothered to go to the gym. I can't be bothered to do much walking. Well, patients feel like that too. So maybe some of those days are when they're not going to pull the wrap as tight as they should. But hopefully the next day they will. Karen has already said, you know, as healthcare professionals, sometimes we don't put patients in the optimal compression. When I bandage a leg, I'm a 120 milligrams per mercury girl. You know, I'm a physio. Everything is quite firm, solid, tight. Maybe some of the newer people coming in, they're less. They're 40 milligrams per mercury. There's nothing right or wrong, but it needs to be the optimum for that patient. There is this lack of knowledge, we've already said. Now, do all wraps do the same thing? Well, yeah, they do. You know, they've got slightly different specifications. There are certain wraps that you might think are slightly firmer. There are certain wraps which patients might think, oh, this is much easier to get on because there's less Velcro bits. But technically, they all do the same thing. The cost, yeah, they are slightly more expensive than garments, but you know what? If a patient's going to wear it, it doesn't matter what cost it is. You can give them the cheapest compression garments, but they never go on their body, or you can give them the most expensive wrap and they wear it every day and their risk of cellulitis is less and their wounds are healing. I know which one is far more value-based. Karen's already mentioned, yeah, they are seen as a last resort. Why? Historic practice, maybe they're not on your tariffs. Some people say they're bulky. Well, they're not as bulky as they used to be, and you can wear your jeans underneath them. They can wear trousers underneath them now. And lots of patients say, well, I quite like it. It looks like a sports garment. It doesn't look like, you know, German ginger, granny-like stockings that fall down. So there are some benefits. Now, what have we done to try and prove the worth? Well, we did a value-based research project. We got 50 patients, and these 50 patients were belonging to lymphedema or had just been referred to lymphedema. And the aim was, if we gave them a ready wrap instead of their previous care, would it actually improve their outcomes and their clinical outcomes? And was it cost effective? So as I said, there was 50, some had a wound, some didn't have a wound. We collected the data on assessment 3 months later and 6 months later. They were all over 18 and they all provided their consent. And we excluded those who had midline swelling. So genital edema, we did not include them. So every participant was given a foot wrap and a calf, plus or minus a thigh knee piece, dependent where their swelling was. Now, lots of people think, oh, the edemas, lymphedema, it's only in the lower limb. And you'd be surprised to know a lot of the patients that we saw actually had thigh swelling as well that we then treated. Now, we collected lots of data, BMI, frailty scores. It was the Rookwood frailty score, and that is 1 to 8 or 1 to 9. Anything over 4 is vulnerable. We did BLS, British Lymphology Society category staging. We did ISL staging, our own lymphedema staging. We did Lymprom, EQ5D, and lots of things then about their wounds, cellulitis, and resource utilisation. And that's important. Who had they seen previous to our intervention? How many times had they seen them? Were they in hospital with cellulitis? How many times they'd seen the GP? Now, this is vital if we are going to get more staff. If we can prove our worth by saying, look, if they use this particular device, if they see us, it saves X amount of money. That's when our finance colleagues will take note of us. And that's why resource utilisation is so important. So, Kat, what were our results?
So demographics, so 64% were female, 36% were male. When you look at the caseloads, that's probably what we would normally see. The mean age was 68. Our BMI average was high, we thought, when we were looking at it, so 43.2. But if we look at a caseload in general, then that isn't a big surprise, if I'm honest. 86% of them bilateral lymphedema. Mel has already mentioned the Rookwood, and 76% were vulnerable, so 4 up to 9 in that coding, and 82% were complex lymphedema. Nearly half had full leg swelling above the knee, and 84% had foot swelling. Now, this is important to me because if you put a wrap on, you've got to consider above the knee and on the foot, because we can cause swelling in those areas if we don't have graduated compression, either the full leg or definitely including the foot, because your lymphatics start at the toes and are all the way up. So we'll push it down if we don't put optimum compression on. And over half had a wound, and then the wound size was between 10 and 25 centimetre squared. 43 out of the 50 completed the study. Our RAPS value-based results. So we have already talked about PROMs, patient-reported outcome measures. The graph that you can see on the top on the left is showing the blue column is pre our intervention, so pre the application and shared decision of using the wrap, and then the orange column is post. So you would want those to go down because you would want the impact on those areas to be less on the patient. So for example, you would want the pain to improve, so the score should go down. You would want the heaviness to improve, so it goes down, and you can see they're all statistically significant. The volume was reduced, not as much as we thought it would. But again, is that our outcome or is that the patient's outcome? If their mobility improves, then surely that's a good outcome. The cellulitis episodes reduced. You could say that's a clinical outcome and a patient outcome. They certainly don't want to be experiencing cellulitis. So it's from 22 to 7. The dressing reduced, so that's dressing cost. That's money saved, so that's really important in the NHS that we're in today. And the community nurse costs went from 942, so this is around calls. I am not in any way saying that we need less nurses. Let me just get that out there now. But what we all need to be doing is using our time efficiently and on the right people. So if you're freeing up that time of a nurse, they're able to go and see the palliative person or another person that needs your call, rather than fitting in 16 calls a day instead of 14, because that's what we're talking about in relation to community nurses. What we did, we took patients out of bandages and put them into wraps. We added wraps over compression garments. We took patients out of a garment and put them into a wrap, and we added wraps over bandages. So we did quite a few different mix and match things. The summary, basically, the overall costs were reduced by 384. The PROMs improved, which you've just seen on the last slide. This population had a high BMI, frailty, and were elderly, and yet there were positive improvements. So for me, although they were what we need to consider about the wraps is, why then do we not use it as a first resource? Why are we waiting until we've tried all those other things and disempowered those patients? The patients reported they were more in control. That is so key. If we feel in control, we're more likely to continue with it. And that will empower people. Wounds healed with all of the wounds had improved to some degree, and the pain and heaviness was better. So we did promote self-management and maximise that.
Okay, thanks, Karen. So what we're going to do now is we're going to run through those pictures that we saw right at the beginning. So this is a typical patient, bilateral lymphedema, been given antibiotics from the GP for cellulitis. She has a wound underneath her right foot that leaks. The community nurse says want a bandage, but the social circumstances are difficult. So Karen, does she have a cellulitis?
Oh, here we go. So do we think it's a cellulitis? Well, it's bilateral. Does cellulitis occur bilaterally? Extremely rare. Is cellulitis a good choice for that? Is antibiotics a good choice for that patient? Absolutely not. If you think about stewardship, that the patient will become resistant. It is not a cellulitis. There is a great lower limb inflammation pathway within the BLS, and I would, if none of you have already accessed it, I would advocate you access it. It directs you as to whether it's cellulitis or not. That is absolutely not cellulitis. And isn't that wound dressing wonderful, and the bandage on her foot? What exactly is that going to do and move any of the fluid? The fluid in the lower limb there is literally going to trickle down into the foot. That wound is never going to heal. And the community nurses, that would be a manual handling risk to bandage. If we think about it, we think about the social circumstances, but actually that's a difficult leg or two legs to bandage. So would wraps reduce the time? Would it empower the patient? So Mel?
Yeah, definitely. So wraps would be beneficial in this point. We would start off in a foot wrap and a calf piece. We would encourage that patient to do some massage around the knees to try and encourage the fluid going up. And we would go in, I would say, every day or so to make sure that that wound is healing and also that those legs are coming down. Now, the social circumstances are important. There are some homes that we go to that are more challenging than others. This was a particular one that was very challenging. This patient was quite challenging too, in that she wanted to be in control, and wraps actually were the solution. Okay. Case study 2. So this is unilateral lymphedema from a gynae cancer. This patient worked full time. She couldn't afford to actually come to the lymphedema clinic. Now, in an ideal world, I wanted to do intensive treatment with her. I wanted her to come every single day for at least 3 to 4 weeks. But she just said to me, Mel, I can't do it. I can't afford the time off. Work won't give me the time off. So we agreed, okay, we'll do made-to-measure garments. But the problem with the made-to-measure garments, sometimes made-to-measure garments are the right thing, but sometimes they're not the right thing. Why aren't made-to-measures always the right thing, Kat?
Well, made-to-measures, you're following the shape of the leg, aren't you? And you don't want the leg to stay at that shape. So you need to reshape and then try and get somebody in an off-the-shelf normal shape garment to maintain that shape. Now that you couldn't get an off-the-shelf garment to that leg, but you've got to reshape it first. Also, made-to-measures can have a 20% tolerance. So a made-to-measure garment can be made and then be made 20% different the second time. So actually, to have a consistent approach, wraps would give you that, and an off-the-shelf garment would give you that once you get to that point. But wraps would put her in control, which exactly what happened. Yeah.
Definitely. And what we did for her was we gave her a thigh wrap. And you might think, oh my gosh, but what happens? Wouldn't it push the fluid down? No, because she was already in the made to measure. She was in the compression at the foot and the ankle. The main area of complaint was actually at the thigh. That's why we gave her the control. Now, other things we could have done with this patient is we could have got her in, we could have measured her, we could have done all the volume measurements, done the proms. We could have then said, right, wear this full wrap system every single day now for the next 2 weeks, and then come back to us. We'll take it off. Obviously, we'll remeasure and we'll do your proms again. She would have obviously taken it off to have a shower and so on. But that way, it'd be mimicking intensive treatment. Okay, case study 3. This was a bilateral heart failure patient, and he loved his stockings, but what he found was the stocking on the one leg kept slipping down and was causing major issues, so much so that he felt he was going back and forth the bathroom all the time, pulling his trousers down to yank it up. Now, we tried silicone, at the top, so to try and keep it in place, but he was allergic to the silicone. And really, what we then did was, do you know what, we need to just put him in a wrap. He's in control. Once that fluid is coming down, and it was coming down really quick, then he could just readjust his wrap, and then it was fine for the next few hours. Case study 4, Karen, this is your...
Yeah, look at those legs. We still see them, don't we? I'm sure all of you watching this will think, oh yes, I've seen legs like that. They're bilateral leaking lymphorrhea. Toes were affected, as you can see. Stockinette and bandage is saturated within an hour of donning them, and community nurses going in daily. So there's 2 things here. The community nurses are doing it for the patient. The other side is that the patient has lost control then, and they are taking control of that. So a wrap in this situation was ideal because it reduces the nurse's time until they're able to empower the patient to be able to do that themselves. The legs obviously need a good wash, as we all know. The skin will improve, but actually leaving those soaking dresses with not enough compression on, you're just in a vicious circle. So the wrap here would, and you might need to consider a knee wrap. You can see that actually his lower leg looks like it's had quite a bit of compression, not enough, but the misshapeness there. So we need a knee wrap over there, and we definitely need a foot wrap, and that improved then, and also reduced the nursing time, and then allowed the patient and his family to take control moving forward from there.
What about patients, Car, that you put all the compression on, you put your bandages and everything, and then they're ringing you 2 hours later to say, love, it's leaking, it's all striking through. What about putting a wrap over the top?
Yeah, absolutely. So, if we talk about confidence and competence, the turnover of community nursing staff and nurses everywhere is high. So if we could get somebody competent to put 1 layer of bandage on, 1 layer of Actico, then maybe put the bandage over the top. That will give you good optimal compression, and that squeeze then would move that fluid away, and then would stop the need for that nurse being called on evening rota, night shift, because we'd move that fluid away much more effectively, and we wouldn't be concerned about new nurses coming in not being able to apply that compression because they haven't been signed off yet. So yeah, absolutely, yeah.
Thanks. So wraps over the top of bandaging, yes, you can. And this last one, so this was my patient, primary lymphedema. She was in a full leg wrap device, so from her toes right the way up to her groin, but every time she kept coming back to me, the swelling was increasing. And she kept saying, oh, but Mel, I wear it for, 8 hours. And I said, okay, well, when do you put it on? Oh, I put it on in the morning and I take it off at night. Okay. So then it makes you think, well, shared decision making, that's her choice, but she actually wanted that leg to go down. And it could well have been that she wasn't pulling the wrap tight enough. So what we did for this lady was we put her in a flat knit off-the-shelf garment, and then we put the wrap over the top. And then she took the wrap off to go to bed. And what we found was within, a couple of weeks, suddenly that limb was coming back down again. And it was all about that the wrap, she wasn't pulling it firm enough. But you can do that if you put a garment on underneath. So definitely you can put a wrap over a garment as well. And I think that is about it for us. So I hope you found the talk interesting. RAPs can promote independence for healthcare professionals and patients. But the important point, we've got to listen. We've got 2 ears for a reason and only one mouth. So sometimes I think we've got to listen carefully to what that patient really wants and not what we want. Clear understanding of what we can do together. And sometimes we have to tell patients that their expectations, their goals are unrealistic. And that's quite hard to have. But it is important. We can't always do what they want because we don't have the resources to do that. Our big thing in Wales, and lots of people say, how have you managed to get 130 members of staff in lymphedema services? Well, it's data. No data is no problem, is no solution. So think about the data you collect. It's not good enough anymore just to say, oh, I've seen 10 patients today, I've seen 15 patients today. Start thinking about, I saw 10 patients and their outcomes, all of them improved. I saw 2 patients last week and I've discharged them. They were only on my caseload for X amount of weeks. Previous to my change in my treatment, they'd been on for years. So think about what you're collecting and so on. But that is us. Now, Alec, I believe it's back to you.
Sure is. Yeah, thank you for that. Very interesting. I was just giggling at your you've got 2 ears and 1 mouth. I think that's something that I'm definitely going to tell people from now on. I'm stealing that one. So there's loads of comments and loads of questions going through, but I thought I'd just tell you a little bit about the poll results because they were really interesting. So the first poll that went up said, when do you consider a RAP with a patient? And 68% said that they consider it at every assessment or treatment session. And then 20% when patients cannot put garments on, and 13% instead of multi-layer lymphedema bandaging, and nobody said they've never considered a RAP. So everybody at some point has considered a RAP. So does that 68%, because that's obviously very high, does 68% of people considering a RAP at every assessment or treatment surprise you, or is that your experience?
Yeah. No, I think that's higher than I would have expected, but that's brilliant news. It is good news.
And then the second one was, and this had a really surprising result. So the second one was, what factors are the main reasons you would choose a RAP? Helping patients to be more independent as a last resort, patient requests a RAP, or never consider a RAP. And believe it or not, 100% of people said that it would be for helping patients to be more independent, which is great on Patient Independence Day. So everybody's doing their bit. Okay, so we're going to get straight on with some of the questions that have come in because there's quite a few, and like me, with the 3 of us being Welsh, we can talk quite a bit. So we'll see how quick we can get through these. So question number 1 is, what happens if you have a patient with lymphedema and normal ABPIs, but all monophasic pulses?
Mel's like, you take that, Kat, you take that. Okay, so I think that's, you need to collaborate on that patient and you need to get some vascular advice, don't you? The problem is, though, if they've got edema, then I would argue that those pulses would be challenging to hear. So I think what I would do if that was the case for me is I would be speaking to my TVN or my vascular nurse, doing a joint assessment and looking at what other red flags they might have, just making sure that the environment was correct when I did it. I would only do a toe pressure. I wouldn't do an ABPI. I would be doing toe pressures on patients with edema. And then it's about good collaboration with the services that we work with to make sure that we can apply compression on them. Obviously it's a standard question, but I'd want to know the patient history. I'd want to know the assessment, but we should be working together. So we've got good links with vascular podiatry, vascular surgeons and nurses, TVNs, and those patients who red flag like that are the ones that need to be discussed as an MDT. Is that okay?
I think Karen's probably the best one to tell you whether that is okay, not me, but it sounded great to me. So question number two is, we have major issues with carers actually maintaining good good leg care post-community nurse input, such as washing and then applying stockings post-leg ulcers being healed. What advice would you give?
Oh, this is a nightmare problem, and we're experiencing it as well. So what we've managed to do is we've gone into those care agencies and we've started putting on education for them. In Wales, we have a suite of patient videos, but they can also be used for healthcare professionals. So the first thing I would be saying is, if you can get in and try and do some education with those care agencies. Now, the only problem with them is the turnover of staff is unbelievable. So suddenly you can have trained, 10 people, you go back in a fortnight and only 3 of them are still there. But it is that constant, re-education. You can do joint visits with the carers, you can talk them through, give them the rationale. And this is something we found important for patients as well as carers, is why it's important to wash the legs, why it's important to cream the legs, and why it's important, to dry in between the toes. So I would definitely say education, education, education. So then they're on board, they're on the lymphedema bus with you. Car, would you say the same or anything different?
No, absolutely. And I think it's the carers understanding the value of what they're doing. So for me, they don't have much investment in education from a lymphedema or keeping legs well point of view. So for me, it's about their role in that is vital. So, they think, oh, I'm asking the care agency just to come and put garments on. It isn't that, is it? It's, applying moisturising cream, it's checking the legs. So, make sure they're informed and aware of why they're doing what they're doing. And then they're more likely then to take that on board as part of the self-care for that patient and keeping them well.
And again, care plans, photographic care plans. We've got some in Wales, more than welcome to share what we've got. So they can actually see something visual, is usually much easier if you haven't done that training, that they can go in and actually visually see what they're meant to do in, where the garment's meant to be, how they get it on. Applicators, donning and doffing garments is not easy, as Karen and I will tell you, when we've got arthritis everywhere. So realistically, getting applicators that can make a huge difference. And there's lots of products out there. So it's teaching them the best and the simplest ways through manual handling, how to get these garments on the right way too.
Can I just say as well, sorry, Alec, we created something in Wales called a passport. So we only did it as a trial with a care home group of people, but actually it's about giving the passport management plan to the patient. So and then that follows them wherever they go. So if they go into hospital or if they go into a care home or if they have carers, it belongs to the person. So then that makes sure that the garments aren't kept on when they're in hospital, and that actually they are removed and they understand. So that's another education tool really as well, and it's management for that particular person.
Thank you. Next question: how do you decide between Acticoat bandaging or bandaging and compression and a compression wrap?
Say that again. How do I?
Well, the question is, how do you decide between going for bandaging? It says specifically Acticoat here, but I guess the question is, how do you decide between bandaging or versus a compression wrap?
So that would be a discussion with the patient, I think. So for me, what we're trying to say here is it probably isn't what we all do, but that's what we should do. So, do we disempower people by putting them in bandages? And actually we lose an opportunity of empowering and encouraging the patient to be self-caring, rather than apply a system and disempower them. Obviously, it would depend on the assessment of the patient. And as Mel said, using our 2 years rather than our one mouth, and sort of saying, this is what we would advise. How would you feel about this? What's going to work for you? Sometimes if compression, I think we always, maybe it isn't what people are doing on the pole, but historically me in clinical practice, I've always considered a wrap towards the end of trying everything else. And I think what we're trying to do, and it might be that everybody listening is already doing that, and that's amazing, is to consider it as a first line. They don't have to have wounds, they can have edema they're trying to manage, but actually it's about having that discussion with the patient, and instead of giving them a decision of do you want beige or black or Actico or another bandage system, you know, these are the options. What do you think would fit in with you and you will be able to manage? And bringing that right up to the beginning of treatment rather than towards the end.
And I think the other thing just to add there is, in most cases, you would try a bandage first. But again, with that patient, come up with some agreement. It may again be, listen, we've got 6 people off sick. I've got 3 people going on holiday. The wrap system is the ideal one. And then that patient might love it and he keeps with it. But if the wrap system doesn't work, that's when you would then say, right, it's not working. Now let's try something different. The big issue we've got in the health, in the NHS is we keep doing the same things, even though they're not improving things. And that's where we've got to stop. The other thing to add is when you bandage somebody and then you're getting leaking through, the wound's not healing, the swelling's not going down, that's when you would add the wrap on top. So those would be the indications then to crank up the pressure.
Okay, great. Somebody has actually asked just for some more information though. So can you tell us more about putting a compression wrap over a garment? We've never done this before.
Okay, so again, we know that garments, although we think, you know, class 1, class 2, class 3, the higher you go in classage, the higher the pressures are. But when we've done a lot of testing on these garments, the garment pressures are on the lowest point. So if we're talking of a class 1, 18, 23, it's more likely to be in the 18, 19 region. Now, when you're walking around, all those muscle pumps are pumping, you've got more hope that that fluid is going to get going. But lots of our patients are bedbound, they're sitting in chairs more often than not, and they're not moving. So just wearing that class 1 garment isn't strong enough to actually maintain the pressure that you've had maybe if you've done bandaging. Now, bandaging 40 milligrams going into a class 1, it's half the amount of pressure. So suddenly that fluid's going to come back, that wound's going to come back, the veins aren't going to be as supported. So you could put them in a class 1 because they can get it on. You may add another class 1 garment over the top, so they got 2 class 1s on. Or you would then put a wrap on top. So those would be my things. So if the swelling isn't going down, the wounds aren't healing enough, think about what else have I got in my toolbox that I could give that patient to help improve their outcomes.
Okay, well, we've got a couple of minutes left, so we're going to try and whiz through a couple of questions because some of these, because we haven't actually asked that many yet. I say this every time, but we do take these questions. We'll present them to Karen and Mel and Eleanor. And if we haven't replied to yours this evening, then we put written answers down, and you can rewatch this. So if you joined late, or if actually there was a queue at some particular station that you happened to be at this evening, then and you missed it, then you can rewatch it tomorrow, and you'll still be able to ask questions, and we'll be able to get back to you. So the questions here, quick fire for this one. So is the study with lymphedema patients, or did they all also have leg ulcers?
They all had lymphedema, and I think over half of them had a wound.
Fab. Would you treat a patient with heart failure any differently in terms of the level of compression?
No.
Yeah, that really was quick fire. Look at that.
Obviously, that heart failure needs to be treated, but if they've got edema, that is the problem. We're doing a massive heart failure study at the moment. 60% of heart failure patients have lymphedema, and only 10% of those are in compression. They're no longer they're all in compression now, and their outcomes are improving, and they're actually feeling much better. So definitely think about heart failure patients.
Fab. And when you start someone in wraps, how often would you have them back in to check on them?
Well, that would depend on the patient, wouldn't it? If we're trying to promote empowerment and self-management, then we would want, depending on how confident that person was, as to when we'd need to bring them back. But in Wales, we're trying to do patient-initiated follow-up. So we're trying to get patients in control of their chronic condition and then just calling us when they need us. So that would be dependent on the patient. The other thing to say about heart failure is there's lots of guidance around for that, for those of you who are a bit concerned about compressing with heart failure.
Well, so all of the information is available in the paper that has just been published last month in the Journal of Community Nursing. You can download it. The Journal of Community Nursing is free. It's on jcn.co.uk. So if you go onto there and go onto the latest journals, if you have an account, you can just read it. If not, you can register for a completely free account. Have a look at that. It's in the June-July issue. You can send us an email and we can send you a hard copy as well if you'd prefer a hard copy, because we've still got some of those left from the viewing packs that we sent out. I just want to thank Eleanor for lots of things, really. Talking about ReadyWrap, I had quite a significant burn on my leg, which anybody who knows me knows I'm constantly injured. A couple of months ago, I had a really, really bad burn. Like, it was in 3 different parts, and the middle part was deep. And I was convinced I was going to get an ulcer. They put a dressing on there, and they measured me for a ReadyWrap, and I wore ReadyWrap religiously for about 4 weeks, and it's healed perfectly. And I know that if I wasn't compressing it, it probably would have been. It was on the bottom of my leg, on the outside of my leg. I know that it would have been a lot worse had it not been for the help that Eleanor gave me. So thank you very much for that, and thank you for your support. Thank you everybody for taking time out this evening. We don't take this for granted, especially on a day like today. We joke about the fact that it's July the 4th and American independence, but there is some really important stuff going on in the country, not least the tennis. And getting out and exercising your democratic right to vote. There you go. I said it. So we really appreciate on all nights tonight you giving us your time. So thank you very much. And I mean that not just for the viewers, but to you and Mel, to Karen and Mel. So thank you very much. The presentation was wonderful. There is some stuff that you can access via the Eleanor website. There should be a slide on your screen at the moment which gives you a link to their Learn on Demand. Their Learn on Demand is essentially it's an online learning platform with so much in there. It's got videos, shows you how to measure. There's lots of articles and things like that you can access. So if you've got any questions, I bet you can find the answer there. So go and take a look at their Learn on Demand section. There's also an email address. So if you've got any questions, specifically either about this presentation, or maybe you want a visit from your local representative or part of their clinical team, then you can email LRUK customer services at uk.lrmed.com and someone will get back to you. In the comments now, there should be a link for you to download your certificate, because obviously watching this evening counts towards your CPD time. I think that's it. I think that's all the thank yous. So yeah, thank you very much. We look forward to seeing you all soon. It's summertime. We've got one more event. We've got one more live event in Birmingham next week on the 10th. So if you're in the area, come along to that. If not, have a fantastic summer. We'll be back with our next event in September. We really look forward to seeing you. And yeah, I hope you have a fantastic, interesting night. Goodbye.